Cooperberg here, who I'm super excited to see and talk to. And he is a famous urologist, but what his official title would be Professor of Urology, Epidemiology, and Biostatistics. And he is a professor at the University of California, San Francisco. And he's also a doctor at the San Francisco Veteran Affairs Medical Center. So welcome, Matt.
Great to see you.
Okay, so we want to know what it's like in San Francisco. To be honest, Vancouver has done really well. I don't know if we're all really obedient or we, just have spent a lot of time outside, but Vancouver is unusual. And hopefully we have no spikes, but things are all opening up here. And yeah, people are wearing masks where they need to. And we don't really have a huge amount of numbers. Unlike the East Coast of Canada, we're doing really well. What is it like in San Francisco?
I'd say probably fairly similar. San Francisco, Northern California in general, has done well. We have had, I think, 20 deaths in the whole city of San Francisco over the entire first surge.
Wow.
A few more if you look at the whole Bay Area. It's about 20 million people in the 6 counties around San Francisco, but it's really only a couple hundred. Very different from even Southern California and LA, and certainly different from the East Coast. The huge questions are why and what really explains this. Part of it, early on, San Francisco was one of the first cities to lock down in the country, sort of middle of March. And even before the citywide lockdown, a lot of the tech companies, there's obviously some huge tech companies in the Bay Area, and they basically sent everybody home even a week earlier than the lockdown. They had folks start remoting from home, and that was 20, 30,000 people that were not coming into the city. And then the citywide lockdown came in about 4 days before the statewide shelter-in-place order, and those interventions got a lot of credit for the city doing as well as it has. It is interesting though when you look at places like Miami, which should be the opposite. It's relatively dense. It's very much older population. There's a lot of comorbidity. People are not the healthiest, and everybody's been ignoring all the orders, and yet they have not had huge spikes. So what really is driving the epidemiology at a local level, I think, is still a little bit unclear. Why LA has done so much worse than San Francisco is not, nobody quite has figured this out yet. But yeah, San Francisco is doing well. The problem now is managing the reopening, and they're going very, very slowly and very cautiously, which is good from the standpoint of viral spread. But on the other hand, it's becoming clear this is a long marathon, not a sprint. They already estimate half the restaurants in the city might not be able to reopen. The impact on the economy is really becoming very desperate in a lot of sectors. And there's areas of the city like the Tenderloin, which is, they've almost given up the rule of law, and the homeless population problem there has become really, really critical, and there's no particular plan. So, the city's done very well from a standpoint of managing the virus, but I think there's all these other implications now that we're going to have to start dealing with, a little bit more actively, because this is not going to be over next month or even by the end of the year.
Did you notice a wave change this Memorial Day weekend? I know internally here in Vancouver, it was the May long weekend, and last weekend, and it was kind of like people are done. And the sun came out and they were hitting the parks, and it was like the veil had been lifted. How about you guys?
Yeah. People have been hitting the parks kind of all along, actually. Maybe after in the first week, I think everybody really was just home. In my job, it turns out about 20% of what I do was actually important. So I've been going to work about, a day a week on average. Now it's up to about 3. But the first couple of weeks, you'd go out and it really felt like some kind of post-apocalyptic, movie. And the streets were just deserted, 3 cars on the road, the sort of thing. That was really just for a week or two. People have been out jogging and biking in the parks for a long time now. And because that's all you can do, the parks have actually been pretty crowded for weeks. And the thing is, 90% of the people are doing the right thing and either distancing or wearing masks. And then you've got, picnic blanket with 15 people from age 6 to 70, all crowded around it with no masks on. And this is what everybody worries is kind of going to be the bad apples that kind of ruin the recovery effort. But it's also becoming clear, I think, from some of the studies that outdoor transmission is really not common. So, masking is definitely one of the best interventions. It's all aerosol. It's all from, nose and mouth. And, I think if enough of the population is doing it, it's just going to slow down the spread, hopefully enough that we can get back to some kind of semi-normal life for as long as it's going to take to get vaccines, which is ultimately what we need. And that is not next week. So, again, if you're by yourself, no, I don't think you need to wear a mask. But I think the idea of kind of just being in that habit of certainly in any kind of public space, the supermarkets and restaurants, when they eventually open, is a good thing. It's a really important thing.
And tell us about the Veterans Affairs Hospital that you work for. My understanding is it collects data from all across your country on veterans, and that's one of the only places that actually does that for all Americans. So is there a study looking at COVID on that data group?
Yeah, there will be. So the VA system is a national system. There are veterans hospitals all over the country. Many of them, like ours, are attached to universities. So the San Francisco VA operates almost as an extension of my university, of UCSF. Not all of them are like that. But yeah, we do have a national data system, national electronic health record system. And they do have pretty good national vital statistics. There are no sort of unique reports yet on the impact in the veteran system. One of the interesting things too is that the VA also by laws is designated an overflow system for the community hospital system, which I never knew until this whole thing started. So, our VA really sort of locked down in anticipation and in fear that there might be this huge surge, which we have not seen. I mean, I think there have only been like 3 cases and no deaths at our VA total. Maybe it's 5 now. Whereas I had friends in the Manhattan VA, and that really is all the pictures and war stories that you hear from New York of, literally converting all the operating rooms and recovery rooms into ICUs just to have more ventilator capacity because people were just dying in hallways. So they took hundreds of cases from the community hospitals into the VA system in Manhattan. So this was very variable around the country. The veterans population tends to be older. They tend not to be the healthiest. There's certainly those who are more at risk of doing badly when they get the virus, but it's not like we've seen a particular surge that I'm aware of within the VA population. Now, again, it's all very local and very very specific to the local conditions. There was just an article this morning on it's really tragic. A veterans rest home in Massachusetts with a lot of these guys in their mid-90s who were surviving World War II vets, and it just tore through. I think 50 out of 80 residents got it, and most of them died of it. It's just awful. And you hear stories like that, and that's that is really what I think is driving all the concern and all the fear. And because all it takes is one case into a place like that, and it's like a tinderbox. Then on the other hand, San Francisco has this long-term care facility called Laguna Honda that everybody thought was going to be our sort of powder keg, and very early there were like 9 cases reported. And then nothing happened. It didn't expand from there, and nobody quite knows why.
Wave 2. Can you sort of like walk us through, from your perspective, how you think that will play out?
We have no idea. Honestly, we really have no idea. The national response has been so unbelievably embarrassingly disorganized, maybe predictable given who's supposed to be running the national response, that we have no national data and no national tracking system. The testing is so variable. So it's very hard to track prevalence of the virus when you don't know how many people have it, right? And there's still not as easy access to testing as there should be. We're still just getting started on contact tracing. The concept that if you get it, there's got to be people around who can figure out everybody that you've interacted with in the last several days or a couple of weeks. And that's critical. That's what they've done very effectively in some of the Asian countries to contain it. And we just do not have that capacity built up yet. And it's been months and we still don't have that capacity. We still don't really know, how many people really have it and have not. There's plenty of people that had these flu kind of syndromes, even in February, that probably had coronavirus. We just didn't know, there's no testing. So in that background, it's hard to predict what the second wave will look like. I mean, yeah, obviously as states open up, you see these pictures from Texas and even Southern California where people are acting like absolutely nothing ever happened, and it's, wall-to-wall people into swimming pools and beaches and stuff. Either this is going to be the next big wave or it's not. But again, the fact that we have not seen it already in Florida suggests that maybe it doesn't spread that easily on a beach as opposed to in the indoor environment, in Manhattan, that sort of thing. But we don't really know. It's a huge risk, and people are taking these risks without a lot of, without a lot of data, without a lot of knowledge, without a lot of capability to respond if this does turn out to be a terrible idea, right? So, it'd make me a lot happier if everybody was at the beach with a mask on, right? Because then you're at least containing things to a much greater extent. So we could see a second wave coming in the summer, or the other theory is, in the fall, as everybody moves back indoors again, and we typically see a spike in these types of viruses. Coronaviruses that cause a common cold usually spike in the fall. So maybe there'll be a second wave then.
The antibody test, and do you think if the entire globe is working on a vaccine, the entire world, could it be faster or?
Yeah, I mean, sure. It's definitely faster than if you only had one company working on it, but it still takes a lot of time to validate, right? It's one thing to produce a vaccine. To run the trial to show efficacy is much more difficult. And it's, I was actually just on a conference call yesterday with an actual virologist who made the really good point that, one of the challenges now is because we're really past the peak in a lot of places. You do a trial of vaccine, you want to track that population and see if they got fewer cases, if they got the vaccine. Well, because the prevalence is falling in general, transmission is falling in general, the case rate is going to fall. So the lower the case rate, the more people you need in your trial, the longer it takes to prove that it works. So it's actually a tricky time to start a big vaccine trial unless you're going to sign up for an exposure trial. And then people are talking about this, where you volunteer to actually get exposed to the virus after you get the vaccine. And which they're talking about doing with healthy people, and ethically, as long as people know what they're getting into. The case rates, there are obviously horrible stories all over the news about young healthy people getting sick, and kids with Kawasaki syndrome and things, but those are really, really uncommon. The vast majority of people who are getting really sick and dying from coronavirus are older and not healthy older for the most part. So I don't know. Will they get 30,000 healthy volunteers to sign up? I don't know. And only a couple of the trials are getting organized that way. But yeah, there is some optimism that things will happen faster. The antibody test is a different story. The part of the challenge is, there's a lot of challenges there. We don't know how long the antibodies persist. So just because you have them doesn't mean they're going to last forever. And nobody's really proven which antibodies confer protection, right? So just because you have antibodies does not necessarily mean you're immune. If you look at measles, if you've got antibodies to measles, you're pretty much good. You'll never get measles. Flu is a different story, and that's why we have to get a flu shot every year, because there are so many different strains and different variances of the flu virus. So just because you got antibodies against the flu doesn't mean you can't catch the flu again. So, and if you look at the common cold, which is sort of the best known coronavirus, obviously you can get a cold every multiple times a year. Some of them are coronaviruses, some are others, but obviously their antibodies do not confer long-term immunity. So we don't really know. It'll certainly be good as a means of tracking who's been exposed and who is already kind of through this first peak of it. But is that going to mean that you can walk around with a mask? Probably not. Is my guess. And the fact is, none of those tests has been well validated yet, unfortunately. What boggles my mind is that we've not been able to ramp up, the viral tests more rapidly. The bottlenecks in swabs and things like that in the first couple months were just inexcusable. But silver linings everywhere, that you look with this whole thing. And one of them has been rethinking how we deliver healthcare. We have a big catchment of our geographic region where patients come to us, both at the University Hospital and the VA. We have guys that come down from the Oregon border, well into Nevada past Las Vegas. And for a patient to drive 4 or 5 hours, wait an hour to have a 10-minute post-op checkup is stupid. It's always been stupid. We've always had these, sort of petty regulatory barriers to doing more remote health. People would worry about privacy on video, and they'd worry about, well, we're not going to pay you the same for this sort of thing. And, what's kind of been gratifying is all of a sudden when we had to, they just threw out, basically locked the bureaucrats out of the room for a couple of weeks and, look what we can actually do. And it's actually been really remarkable. Within a week, we were up to about, something like 50 to 60% of the visits that we were seeing before, we were now doing by Zoom and, other platforms. And it's been working pretty well. It's not a complete replacement for in-person care, obviously, but I think especially for follow-up visits, it makes a lot of sense. And this will be here to stay.
Are there any silver linings with you and your family?
It's been really nice to be home. And again, we are really thinking about it. I mean, it's probably a lot of the work that I do in, at on site that's kind of more officey and researchy, eventually, yeah, maybe we'll do that at home long term.